Good evening, everybody. Welcome. Thank you for joining us tonight. This is the Spine Time webinar, and it's being sponsored and featured by the Weill Cornell Center for Comprehensive Spine Care. It's meant to be a really patient-focused webinar about issues pertaining to spine health, treatment of pathology, and of maintenance preventative care. We are joined tonight by Dr. Kai-Ming Fu, who is one of our spine surgeons at Weill Cornell and director of our scoliosis program. We also have Dr. Pak, Daniel Pak, who's one of our pain management specialists. And we're going to be talking tonight about scoliosis, specifically what are the treatment options. So this is adult spinal deformity for the most part. We're going to be talking about degenerative spinal deformity, where clinical presentations range from axial back pain, so midline, thoracic, or lumbosacral region back pain, so just our standard back pain, plus pain that can radiate into the legs, weakness in the legs, which would be considered in the category of neurological deficits. Postural problems, feeling like you're tilted to one side, or that your center of gravity is off to one side, or that you are unable to hold yourself up. These are possible symptoms or manifestations of adult spinal deformity or scoliosis, and ultimately these cause functional limitations. So our standard workup for this is the initial evaluation. And this is going to be the basics, which we do in all medicine: history, physical exam, and imaging review. And based on that, our goals will be to overall increase the health-related quality of life by managing pain and symptoms. And we can do that through what we call conservative measures, things like physical therapy and strengthening, to minimally invasive pain treatments, which Dr. Pak will talk to us about tonight, and then as well as surgical options. And Dr. Fu is going to illustrate some of those for us this evening. So this is meant to be an interactive forum. We're happy to get questions, and that's really what we'd like to depend on our audience for, to get the discussion going. But we do have a little bit of a presentation for us prepared. So here we are with the Weill Cornell Spine Center: pain management, complementary medicine, rehabilitation, mindfulness, reduction in CBT, neurology, as well as spine surgery. And those are the fundamental components of the Spine Center. These are our speakers for tonight. So just by way of brief introduction, Dr. Kai-Ming Fu, he's one of my partners in the surgical practice and the surgical arm of the Spine Center. He completed his training at Stanford and then his residency at University of Virginia. He's currently the chief of neurosurgery at Lower Manhattan Hospital and the director of spinal deformity and scoliosis here at Weill Cornell. And his practice largely focuses on revision reconstructions, as well as open and less invasive techniques to manage scoliosis. And we'll get to him in just a moment for his part of the presentation, but we're going to start with another one of our partners, Dr. Dan Pak. And he comes to us formerly serving as faculty at Mass General and Harvard Med School, where he was the director of the intrathecal drug delivery program. He's dual board certified in both anesthesiology and pain medicine. His specialty is interventional pain management, and this comprises his clinical focus, which is injections, stimulators, and pain pumps. So with that by way of introduction, we will start with Dr. Pak. Dr. Pak, are you with us?
Can you hear me?
Fantastic.
All right, thanks, Dr. Virk. So, I think for most of the patients we see with scoliosis, I think initially we'll always try to initially take a conservative management approach. And really this involves maintaining and improving function versus and pain versus an actual correction of the spinal deformity, which is something that Dr. Fu will talk much more in detail about. But this entails a variety of different things, including some of the stuff that Dr. Virk already talked about. So that includes physical therapy, a variety of home exercise programs, bracing whenever that's appropriate. Weight loss is also very important, so it reduces the amount of stress on the spine itself, and also medications and injections whenever we feel that patients are candidates for those. Next, please. So one of the hallmarks of conservative management is physical therapy, and probably one of the most common techniques that's utilized is something called the Schroth method, and this is specifically for patients with scoliosis. These are 45-minute sessions. We really encourage our patients to do these regularly, so on a kind of a weekly basis, and you can do these also at home as well. It's really tailored to a patient's unique spine curvature. Now, there are basically three major components of this kind of therapy. So, for a lot of our patients with scoliosis, they have on one side of the back, the muscles may be kind of weakened and also wasted away. And on the other side, the muscles may be overworked and more prominent. So Schroth exercises really promote and are designed to address both of these problems and aiming really to achieve muscular symmetry. In addition to this, a lot of patients with scoliosis, especially with kind of more severe curvatures, a lot of these patients will actually have restrictive lung issues, meaning they have difficulty breathing as a result of their curvature. And so the Schroth method really also utilizes different breathing techniques because of these problems, and it helps patients improve their kind of ventilation, also respiratory function, and also ultimately improving patients' posture. So this utilizes different modalities such as mirror therapy. Now, this is kind of more formal physical therapy that patients can participate in as a kind of as an outpatient basis. Now with COVID, obviously with people trying to stay home more often, we do encourage home exercises as well. So this can comprise of things like planks, leg raises, supine hip thrust, for example, and also light weightlifting. All this is designed to really strengthen abdominal and back muscles, not only to improve posture and promote things like symmetry, but also improve pain. Next.
Great. So Dan, before we go on with this, there's one question here from one of the audience members. She's writing in to ask, is there any chance of improvement by non-invasive methods for somebody over 75? And I think you were touching a little bit on this right now. You're discussing some of these non-invasive, but where does age play into this? Is this something that people can try at all ages, or do we get an age cutoff? How do you see the role of age in treating scoliosis and symptomatic?
Sure. So something we know that is so the vast majority of scoliosis cases are in adolescents and in children. That's when it starts. And so we do know that doing these exercises and doing things like PT regularly does reduce the progression sometimes of a lot of these deformities. Now, I think from a symptomatic management standpoint, all these things definitely help. So in terms of improving your core muscle strengthening, that's something that can be used at all ages. And so I think, even with advanced scoliosis, if you're really looking for a non-invasive approach, these are all things that we definitely promote and encourage patients to participate in. Hopefully that answers your question.
Great, yeah.
So moving on, bracing is also something, I guess, to add on to other kind of non-invasive modalities. Bracing is somewhat of a controversial, I think, subject. A lot of patients will use basically these custom molded plastic braces, which can help actually provide symptomatic relief and in some cases can prevent progression. But it's also you also have to be mindful of the fact that it can also cause much muscle atrophy. So if this is something that you're interested in or have entertained, I would do this under the guidance of a physician or a spine surgeon. Some patients find that, for example, soft braces are actually much more comfortable just because, they're a little bit less restrictive, and these can improve ambulatory function, for example, but it's not really proven to stop progression in kids or adults. So, if this is something that you're entertaining, I think this is something that should be done with the guidance of a physician and also a physical therapist, for example. Next. So when we're talking about conservative management, we really try to approach this from a kind of a multi-modality standpoint. So in addition to physical therapy and doing home exercises, we try to utilize non-opioid medications whenever appropriate. And so this includes medications such as non-steroidal anti-inflammatory medications, neuropathic pain medications. These are medications that you may have heard of, such as gabapentin, Lyrica, or Cymbalta. And these are specifically for patients with shooting pains down the legs, which is something that we'll talk a little bit about more in the next couple slides. A lot of the patients with scoliosis also have pretty symptomatic muscle spasms, and so muscle relaxants can also be utilized for these patients, and topical medications whenever appropriate as well. Next. Now moving on to injection therapy. So, scoliosis can lead to unbalanced loading of the spine, and as a result of that, several degenerative changes. So this can lead to an arthritic component to the spine, and also a degenerative disc disease that can ultimately cause narrowing of some of the openings where the nerve roots exit the spine. And so where you do have compression of these nerve roots, patients can complain of lumbar radicular symptoms. So this was something that Dr. Virk had touched upon, but patients can present with shooting pains down one or both legs, and have associated numbness and tingling, and weakness is also seen in severe cases. And so when that's the case, oftentimes we'll offer patients something like a epidural steroid injection. And what that is basically entails is, under the guidance of an x-ray, to use a small needle and deposit essentially local anesthetic and steroid in the areas we think are actually causing the pain. Now, these have been pretty successful in providing pretty good symptomatic relief. And I think the benefit of something like this is not only is it a treatment tool, but also a diagnostic tool as well. And there's no recovery process afterwards. Typically, the injection itself takes about 10 minutes. So for the right candidate, can be a good way of managing someone's symptoms. Next. Also, back pain is probably one of the more common symptoms that patients present with. And so this is oftentimes due to stress on the joints of the spine. Typically occurs more in the lumbar spine, so in the lower lumbar spine, but it can also occur in the mid-back or thoracic spine as well. So, when patients have failed some of the other conservative options, then we can do something like a facet injection. What this involves is placing steroid into the joints of the spine in those degenerative areas, which can provide some symptomatic relief. Next. And an alternative to that is to provide a medial branch radiofrequency ablation. So when a patient presents with axial back pain or mid or lower back pain, you can try to provide relief by injecting steroid into the joints themselves. You can also go after the nerves that actually innervate those areas of the spine. And so what that involves is taking a very small cannula. We apply heat to those nerves, and that essentially you can think about it as cauterizing the nerves. But these are nerves that don't have any higher function. So, the most common question we get asked is, you're burning nerves, or you're doing something to the nerves. Does that cause any potential side effects? And I guess my answer to that is these nerves don't have any function from a sensory or motor standpoint. They just kind of control pain, which enables us to do this procedure. So by doing a radiofrequency ablation, we can typically give patients up to about a year and a half of relief in terms of their axial back pain. Now, those nerves do grow back, but they grow back a little bit weaker, and this is a procedure that we can repeat. So again, for the right candidate, can provide pretty good relief for back pain. Next. Now, when these modalities haven't worked, and we do see patients like that, and they're not surgical candidates, then we can talk about something like spinal cord stimulation. Now, I won't go into too much detail of what this involves, but basically the therapy essentially scrambles the pain signals from reaching perception in the brain. And so this technology it's been available since the late 60s, but the technology over the last decade has improved tremendously. It is an implantable therapy, meaning there is a battery that's implanted, and there's basically electrodes that go to the spine that do the scrambling of those pain signals. But the nice thing about this therapy is that before you actually commit or go through the permanent implant, you go through a trial phase, which essentially means that we place those leads and we tape the battery to the back. And so the patient goes home for about a week. They're able to test drive the therapy, really see if they get benefit from it. And what we're talking about is not 20, 30% relief, but we're looking for something remarkable, something like 80%. And so at that point, you can have a discussion with your pain physician about whether this is the right therapy for you. Now, so some of these are some of the options that we have available, but certainly not an exhaustive list. So if any of these are of interest to you, please come see us at the Spine Center. I'm going to now turn it over to Dr. Fu to talk about the surgical options.
That's great, Dan. Thanks. Just before we get to Dr. Fu, there are a couple questions there are several questions. Most of these we're going to get to at the end. I think that they're general questions that we can all maybe get involved with, but there's a specific question here. So is it safe to have an ablation with von Willebrand's bleeding disorder and primary immune deficiency? So people with bleeding disorders on anticoagulation, sometimes, for surgery, we're always very concerned about that. What do you say to patients who might be candidates for radiofrequency ablations and who have bleeding disorders such as von Willebrand's or on anticoagulation?
Sure. So for von Willebrand's, I guess it depends on what kind of von Willebrand's you have, right? So there's 3 different types. Oftentimes that's a conversation with the patient, because if you do have von Willebrand's, for example, you are at increased risk for bleeding. The procedure like a radiofrequency ablation, luckily, we're not really around any of the major vessels. And so, something like an epidural steroid injection, we would want someone to be worked up for that and make sure they're not at increased risk of bleeding into the spine. But for radiofrequency ablations, oftentimes I won't actually stop a patient's anticoagulation because even if there is bleeding, it's not actually bleeding into the spinal canal itself. So if there is bleeding, it would be something more along the lines of hematoma, but that doesn't necessarily put the patient at risk for any kind of major bleed. So, it's a conversation that we have with the patient.
Great. Dr. Fu, should we move over to you now and start introducing the surgical indications for treatment of scoliosis and what this looks like?
Sure. I think that, we work together as a team, myself, Dr. Pack, surgeons and pain management, as well as physical therapists and rehab doctors to try to, treat patients holistically for the scoliosis. So my part is really when other areas don't work anymore and you still have significant symptoms, surgery then is an option that you can consider. And, scoliosis is actually a common finding in adults, especially as we get older. And some studies out there show that up to 60% of people may have some form of scoliosis, usually mild. Most of them are asymptomatic. And again, as what we've been going through in the last few slides, non-operative management is usually the first line of treatment. It's very rare that you would come and see somebody for a surgical opinion unless there was a significant problem that had developed. So scoliosis can result in pain, and a lot of times this pain is due to imbalance and pressure on the spine, and specifically the nerves that are coming out in the lumbar spine. So on the left here, we have a little diagram which shows what we call the cone of economy. So when you're standing upright, which is the center man, you have a really good balance. And so your muscles actually aren't working as hard as if you were the person on the right who's leaning forward and off to the right, or the person on the left who's leaning backwards and off to the left. If you are any one of those guys, you are going to be stressing the muscles in your legs, in your hips, and in your back, and this is going to lead to pain, as well as you'll have some structural component pain from the scoliosis, as the bone and on bone can cause some pain. And if we look over here on the right, you can see an extreme example of somebody with significant scoliosis who has both what we call a sagittal plane, or basically bending forward, as well as a coronal plane, in this case, bending off to the left. So this patient can barely stand up straight and is really struggling. And as the day goes on, the pain gets worse and worse. And it's really only relieved by sitting and sometimes laying down. So this is one way that scoliosis can cause pain. And this is one way it's treated, which is the therapies which can strengthen muscles and help you rebalance. But sometimes, especially in the case of this patient on the right, the imbalance is just too great for non-operative measures. We go on to the next slide. And scoliosis can also result in pain, especially in the legs, due to compression of the nerve roots. This is a zoomed in picture of that same patient. And as you can see here, there's basically like a V, where one side of the bone, in this case the left side, is touching the other side on the left. And here on the right side is a little diagram which shows where the nerve comes out, the neural foramen. And on the bottom, you can see when that gets closed down, especially in the scoliosis, you can have nerve pain, and this can cause significant leg pain. And this is one of the things that we look at when we have patients come in with leg pain, as well as back pain and scoliosis. Can we go to the next slide? And so surgery especially in this case, aims to correct the balance and decompress the nerve roots. So in this case, this patient required a pretty extensive surgery to stand up straight, both left and right, and forward and back. And you can see here the results of the surgery versus before. But what this also does is decompress the nerves, because as you're straightening out the spine, the pressure on the nerves is better. So this patient had better back pain as well as leg pain. Now, this is a pretty extreme example of a significant scoliosis, but not all patients who have scoliosis have such an extreme example. Can you show the next slide? So again, this is a case of somebody who presented with back and leg pain and has really no problem forward and backwards, but definitely left and right has a coronal scoliosis. And because of this, he has significant foraminal stenosis, and this is causing leg pain. And so these cases can be treated in a much less invasive way. Next slide, please. So in this case, we did a lateral interbody fusion, and we also did minimally invasive posterior instrumentation. And the way this works is we try to open up the nerves, not by directly decompressing them, but by opening up and correcting the deformity at each level. So here you can see on the left, there's a nerve being pressed down by the scoliosis at that level. And when you do the fusion from the minimally invasive approach, here you can see the cage in place. It straightens up that side and opens up the nerve root, allowing the nerve to be healthy and have less pain. And so we did this at 3 different levels, along with what we do here is a minimally invasive way using the latest computer navigation to place the screws essentially percutaneous with less muscle dissection. And this allows for a circumferential, less invasive approach to deformity. And so if we look at the next slide, this patient had a correction of the deformity at those levels, opened up the foramen, and never really had to have any significant muscle dissection. So I think, the takeaway from this is every patient is unique. Every patient has different needs, and there are different ways to treat every person's scoliosis. From non-operative to when it is operative, there are less invasive options available for some patients. So that's just a brief overview, and I'd be happy to take any questions that may come up.
Great. Well, thank you very much, Dr. Fu, Dr. Pak. We have got a couple questions here. Maybe we'll just start off with this. Some of the audience members have written in, and maybe we can run through a few of those, answer those. So a patient who has leg symptoms, radiating pain, and tilting to one side with a minimal scoliosis, is the scoliosis the issue? Does the scoliosis need to be fixed in order to address some of these other symptoms? What's the algorithm for going through this, Dr. Pak? What would you say? So somebody who's got leg pain, numbness, tilting to one side, they had some imaging, they just found out for the first time, as an adult or perhaps an older adult, that they have a scoliosis, but it's minimal. How do you address that with the patient if they want to know whether or not the scoliosis is the primary problem?
I think, as you mentioned, the first thing we'll, in addition to actually examining the patient, we'll take a look at imaging findings, right? So, a lot of patients will come to us. Sometimes they'll come to us with an MRI, and the MRI will give us a little bit more information in terms of what's actually causing those shooting pains. So it may be due to the scoliosis, but as we talked about, the scoliosis can also lead to a lot of degenerative changes that causes compression of the nerve roots, for example, or the compression of the nerve roots causing those leg pains may be independent of that scoliosis. And so I think the imaging really helps us in terms of, how to proceed. Now, if you have shooting pains down the legs and you haven't tried the conservative measures, then usually the first thing we'll recommend is something like PT. But if it tends to be pretty refractory, or if the pain is particularly bad, then we'll recommend something like an epidural steroid injection. And I think after that, then depending on the patient's progress, we can talk potentially about other kind of corrective measures. But that's typically how we start with evaluation of these patients. Dr. Fu, do you have anything else to add to that?
Yeah, I think that's a very concise way of stating it. I mean, the minimal scoliosis depends on where it is. And, one of the things that you will have when you see somebody, either a a spine surgeon or a pain doctor is they're going to try to correlate where your pain is in relation to any potential deformity that you may have. There are definitely some patients that have some scoliosis, but the problem may be far away from that. And in that case, you don't need to correct the scoliosis necessarily to get pain relief. And there are some patients who have both stenosis, either central or foraminal, where nerves are compressed, in the midst of a deformity. And then, the deformity may need to be treated. But I think, what Dr. Pack says is that, like I said, every patient is evaluated and every deformity is evaluated to see if that's, a potential cause of your symptoms.
Yeah, I completely agree with those responses. And, we see the converse too, the late 70s, early 80s, mid 80s patient who's known about their scoliosis for 30 or 40 years. And they've always been told they need surgery, and they're doing quite well. But all of a sudden, recently, they know that they have a little bit of back pain, but mainly it's a single distribution leg pain. It's going right to one spot, and it's going to that spot over and over and over again. And it's getting worse. And they want to know, is there something we can do just to deal with this single pain source of pain? Can we identify it? Can we treat it? Or do we need to fix the entire scoliosis? And that's also, a situation that we find ourselves in. And oftentimes we can address unilateral, a single radicular symptom or radiculopathy with some of these pain techniques. And it doesn't require addressing the complete scoliosis. In fact, often we try not to really do extensive surgery on patients as they get later into their 80s. So I think that every patient's situation is so unique. It really requires a individually tailored treatment program after they are appropriately evaluated. Another question we have here. So with respect to scoliosis and hips, and people who are told that they have hip problems, maybe they need their hip done first, or they've got pain in their lower back, hips and backs, and perhaps if you could also just touch on sacroiliac joint pain that patients might experience. How do we evaluate this, and what are the potential treatments? Dr. Pack, you want to start with that?
Yeah, sure. So, sacroiliac, if we're talking about sacroiliac joint pain specifically, that, oftentimes there's a lot of overlap when it comes to pain that comes from the lumbar facets or the joints of the lumbar spine, and also the sacroiliac joints. I think some of the more differentiating factors is the sacroiliac joint pain tends to be a little bit lower down, so it tends to present more as kind of a buttock pain. And patients will typically say that the pain is worse with sitting, or maybe changes of position, for example. There are other provocative maneuvers that we can actually do to elicit that kind of pain in the clinic, but there is a lot of overlap there. But we do see a fair amount of sacroiliac joint related pain in patients with scoliosis, and oftentimes that's just due to the kind of the asymmetric loading onto that area of the body. In terms of interventions, there's definitely certain things that we can do for that. In addition to exercises specifically designed to help with kind of offloading some of the stress onto the sacroiliac joints, we can also do sacroiliac joint injections. And those are some of the things that we start off with. I know Dr. Fu has other kind of corrective measures for that pain specifically as well.
Yes, as Dr. Pack mentioned, the sacroiliac joint can often be stressed when somebody has a deformity just by the abnormal forces and the imbalance. And this can also increase hip arthritis as well. And all three kind of work together sometimes to cause pain. And so teasing that out requires a good examination and history taking. And then again, it's also clinically tested by injections. And then, if it becomes refractory to those injections or other treatments, there are very, minimally invasive procedures that can be done to help with the pain, if that is the main pain area.
Great. The question about spondylosis and scoliosis. Yeah, spondylosis is our general degenerative disc change. Okay, so as we get older, our discs, they're hydrated structures, cartilaginous structures. They're actually quite complex with respect to their biomechanical properties. But basically, there's a ring on the outside that's tough, and then there's a soft, very hydrated core in the middle, the nucleus. And over time, discs collapse. And when they collapse, we get more bone on bone articulation. And this can lead to a variety of problems. Dr. Fu had some illustrations of that neuroforamen where the nerve exits the spinal canal. And as those foramen get smaller, potentially due to either disc collapse or some sort of asymmetric collapse, the nerve pain or nerve symptoms can become more prominent because nerves do not like to be compressed, and that's what happens. So spondylosis is degeneration of the disc and collapse of disc spaces and general segmental degenerative disease. With respect to, there's a question about stand-up MRIs versus inside the MRI, and also to check on this, if you've noticed, Dr. Fu's, he's always showing these standing films, okay? So it's extremely important to understand this, that CT scans and MRIs are generally obtained with the patient lying on their back, right? So when you're in the supine position, that's certainly not the same when you're standing up under axial load bearing, right? So when you're under load, the spine that's when a deformity can manifest. In fact, when you lie down, sometimes people look fairly straight, and we call those flexible deformities as opposed to rigid deformities because they change depending on what position you're in. So evaluating a scoliosis with somebody lying down in an MRI or a CT is not appropriate. We need you to be standing up, okay? So we need you to stand up, and we get all these different shots. There's a couple shots that are illustrated right here on the screen right now that you can see. We need a minimum of 36 inches. So we really need the above the orbit, so above the head, all the way down through the hips, and even longer than that if that's available. Some X-ray modalities allow us to see the entire body. So it's very important to evaluate a scoliosis with those modalities. Okay, so there's a question here about leg length discrepancy and whether or not this either contributes or causes scoliosis. How do you guys deal with either pelvic obliquity or leg length discrepancies with respect to scoliosis?
Well, Mike, I think that, it's sort of a chicken and an egg issue. For the most part, if somebody has scoliosis, especially when they're younger, they may have a leg length discrepancy. And usually as you get older, that becomes more and more noticeable and may become more and more painful. And so it can be treated, at least initially, with lifts asymmetrically, depending on which leg is longer. And that can also rebalance and sometimes help decrease some of the pain associated with that leg length discrepancy. Great.
There's a question here from an audience member, and I think this would be actually a good question for you, Dan. So the question is really along the lines of, I've got severe scoliosis and I take pain medications. There's a whole cocktail in seeing a physical therapist. But the patient feels like there's still a lot of pain, and the leaning is getting more noticeable, and having difficulty standing straight. So she's seeing a pain specialist. She wants to know if she needs to see a neurosurgeon. At what point, Dan, do you say, well, you know what, this is the time where we go from trying more conservative measures or repeating conservative measures to moving on to seeking surgical care? Do you have specific guidelines for when the care to maybe perhaps progress beyond the conservative realm into the surgical realm?
Sure. I mean, I think if when the pain really starts to get worse and also functionally the patient feels like they're really becoming limited secondary to their pain or kind of their physical limitations, I think at that point is a good time to talk about maybe kind of a more corrective solution, provided that they are a good surgical candidate. So, a lot of times what I tell my patients is, it might be worthwhile to speak with the surgeons and with you guys to just have that conversation, right? It doesn't necessarily mean that you're committing yourself to a surgery, but, you guys are the specialists when it comes to kind of correcting a lot of these deformities. And so it's good to just kind of get them plugged in with someone such as a spine surgeon, just to start that discussion. If they're not, at the end of the day, if that conversation is such that they're not surgical candidates or they don't want to go that route, they don't have to do that. But I think especially when patients start to say, I've exhausted the injections, I've been doing PT for a while, and I don't feel like I'm getting any better. And I think at that point, it's a good time to maybe have a referral to see a spine surgeon.
Yeah, that's actually a really important point. And both you guys have mentioned this, and I'll just reiterate it that we tend to follow these patients for months to years. Now, there are some hard indicators for surgical intervention, rapidly progressive or new neurological deficits, such as leg weakness, certainly anything that has to do with the saddle region, numbness, bowel, bladder. Those things are unusual, but they need to be recognized and intervened on. But short of that, patients with pain and progressive pain and postural concerns, we tend to follow these patients for a long period of time. Maybe what do you think? How long are you following patients for? Some of these more severe scoliosis, or even the minor ones. How long would you say you follow patients for? And is it an indefinite thing, or do you give them criteria by which they should measure their progression and get in contact with you if they think they should be revisiting the surgical option?
No, I think that's a great question. I think that overall, every patient, as I keep stressing, and I'm probably a broken record, is a little bit different. And I like to see people who sometimes go, well, hey, I think I have scoliosis. And, I will say when people get a diagnosis like that, and sometimes they have it and sometimes they don't, that the best thing I can do is tell them that you don't have it. But if they do have it and it's minor, I usually tell somebody, well, I'm happy to follow along, but for the pain issues, we should start with something a little bit less invasive. And then usually I see people yearly with x-rays unless something changes. And I'll follow people 5, 6, 7, 8 years, and I've had people a decade out who are still following up yearly, and sometimes it's every 2 years. But these things we know progress over time, usually about 1 degree per year. And it's good to be plugged in with somebody. And also when you're plugged in with a complete team with pain, physical therapy, and a surgeon, you can have a more holistic approach to your spine, because I'm going to be looking, is your bone density normal? Do you need to see an endocrinologist to help you with your bone health? How is it progressing? Is there any warning signs? So you're going to have a lot more eyes looking on you. And I think it's a good idea to engage with a spine surgeon, even if you're not ready for surgery, just to know where you stand, what your potential options may be, and what you may need to do to keep yourself healthy and maybe avoid surgery.
Yeah, those are all very important points. So this is something that we follow over time, and we try to manage over time. And eventually, you may cross over to becoming a surgical candidate, and perhaps not. Perhaps we're able to continue to give you options that work. And again, the goal is to maintain your the highest level of function, to optimize you to the best of our ability to keep you functioning. There's a question here about legs dragging and feeling heavy. And I just want to say that can oftentimes be an indication of weakness. When your legs start to feel heavy, or if you feel like you're unstable on your feet, those are two concerning things that should be evaluated. It doesn't necessarily mean you have scoliosis. Certainly that would be, jumping many levels down the line from a diagnostic standpoint. But for instance, if you get, as Dr. Fu just mentioned, getting involved in a place that has multi-modalities, multiple specialties available, can really keep you evaluated in the proper forum. For example, that could be a neuromuscular disease or some other neurological thing. So we would refer you, we'd rule out anything severe like frank nerve root compression, and we can do that with imaging and a physical exam. And if it gets outside of a mechanical or structural problem, then we have neurologists on the team, and we send you, and that starts to broaden the differential diagnosis, meaning to broaden the options, the possible diagnoses that you might have, and at least get you worked up appropriately so we can determine that. But that is something that I would suggest not sitting on and seeking the care of a physician. One other thing that I wanted to touch on, Dr. Fu, you kind of, and I know you started to do the spectrum of the available options, because we really do see scoliosis as this continuum of severity. But how do you, a lot of patients, the first question they want to know is, I need surgery. Am I a minimally invasive surgical candidate versus do I need to have open surgery? Can you take us through the basic, the broad, it's a very nuanced question, but can you take us through the broad brushstrokes of how you make that determination?
Sure. I think, number one is we take into account, a patient's history and, some of their diagnostic issues. So if somebody's had multiple surgeries in the past and this deformity has developed despite these surgeries, then they may not be the best candidate for something less invasive because a revision, may require more open surgery. If somebody has a very severe deformity where they're, unable to stand upright, then currently the less invasive techniques may not be the best option for you. But if you have a lesser degree of deformity and you have imaging that may show that we can give you a very good chance of feeling better with something less invasive, then those are the patients who, we discuss the less invasive options with. And, anybody you go see will be frank and honest with you with what your options are. And, if you do have a less invasive option, and it's always something to discuss.
Fantastic. Yeah, I think it's important to find out what your options are because there are a lot, and certainly some are for some people, and some may not be appropriate for some specific indication. So it's really important to be evaluated across the spectrum. But it looks like the questions are winding down here. I think we touched on most of these, and if we didn't, I apologize. Some of them are very specific about diagnoses, and those, we would be more than happy to reach out if you're able to get in touch with the Spine Center. We can get you an appointment, get you evaluated, because these are some of them are quite specific. But if there aren't any other questions or any other points that either Dr. Fu or Dr. Pak would like to make, I think we're going to move towards wrapping this up. Dr. Fu, Dr. Pak, do you have anything else, any closing points, any other things you'd like to mention? If not, go ahead.
I think Dr. Virk, I would say, I just want to emphasize that, again, if you feel that you have this diagnosis, or if you have this diagnosis based upon some of the imaging you had, you really should go to a center that can give you a comprehensive evaluation. And that doesn't mean just surgery or just pain management or just physical therapy. You want a center that can look at you from multiple different angles and give you all your options so that you can choose what is best for you and you don't get fit into something that may not be the right fit for you.
That's absolutely.
Yeah, and I think, that's also something that, that we have at both spine centers. So we have a spine center at the Midtown Clinic, but as well as the downtown clinic. And so, we have a vast array of resources there. So not only just pain management physicians and surgeons, but also physiatrists, neurologists. And so I think that's the benefit of being in a multidisciplinary center.
Fantastic. Well, thank you both. Thank you both to our panelists as well as to our audience members. Thank you for spending this hour, an hour of your evening with us tonight. Hopefully it was informative. We're always happy to follow up with you in a more personalized basis at one of the centers. And we wish everybody good health. So thanks very much and have a good evening.